Assalamu alaikum. It's really an honor to share in the Upper Egypt Diabetes Association conference, and I should be thankful to the invitation of Professor Khalid Hadine and Professor Misbah Kamel. And as an endocrinologist, I'm going to speak about the polycystic ovary syndrome. And I think the next 14 minutes, inshallah, I will convince you that the role of endocrinology in PCOS is very important. We will follow shortly the following steps: history, hormones and PCOS, the PCOS phenotypes, the role of thyroid and prolactin in PCOS, male PCOS, and lastly, the role of hormones in treating PCOS. The history, you know that the PCOS is dating since the Hippocrates era. This was almost 500 years before Christ, and he described women with who are robust and masculine appearance and are not concerned about bearing children. And this is the description of Hippocrates. But in the recent era, in 1935, in the famous paper of Irving Stein and Michael Leventhal, they discussed the PCOS in details. But before I go through the lecture, let me remind you and remind particularly the junior staff that you have to exclude what is the so-called secondary PCOS. And because PCOS can occur with congenital adrenal hyperplasia, androgen secreting tumors, Cushing syndrome, and acromegaly. So you have to exclude these 4 conditions before labeling the patient as polycystic ovary syndrome. What about the roles of hormone in PCOS? You know, the etiology of PCOS is very complex. There is a genetic background, a background of inflammation, lifestyle factors like poor diet, smoking, and obesity. But mind you, the role of hormones is very important. You've got excess androgen, and this excess androgen can lead to excess insulin. And at the same time, the excess insulin can lead to excess androgen. So there is a two-way relation between excess androgen and excess insulin. The role of pituitary gland is very important. You know, this patient have got a high LH in relation to FSH. This high LH will lead to increased testosterone from the ovary. You can see that this is the ovarian stroma, and the LH being increased more than FSH will lead to more production of testosterone from the theca cells. And on the other hand, the insulin resistance hyperinsulinemia has got a very important role. It can lead to increased testosterone. It can lead to hirsutism by diminishing the sex hormone binding globulin production of the liver. So when the 1-HSBG is low, you can get hirsutism, and at the same time, insulin resistance and hyperinsulinemia can lead directly to polycystic ovary syndrome. The role of the AMH, the anti-mullerian hormone in PCOS, is very important. You can see that patient with PCOS, they've got a higher level of AMH. The AMH is not only occurring in boys, as we have been told in medical school, but also the AMH is produced by the large pre-antral follicles. And this AMH is excessively produced in the patient with PCOS. And this excessive AMH can lead to negative effect of FSH. This is why high MSH will lead to diminished ovulation in these girls or ladies. The third point is the PCOS phenotypes. You know, the PCOS is not only PCOS, it's associated with other comorbidities: hypertension, diabetes, endothelial dysfunction, macrovascular disease, coagulopathy, dyslipidemia, and obesity, and the famous acanthosis nigricans. But mind you, there are 4 main phenotypic categories of PCOS. According to the presence of hyperandrogenemia and hirsutism, and this of one of our patients, PCOS on ultrasound, and excessive androgen in the blood. We've got the classic type 1, the classic type 2, and the ovulatory type, and the normal androgenic type. If you got the 3 present, this is type 1. Got the hirsutism and the excessive androgenesis is type 2. Ovulatory, there is PCO on ultrasound with hirsutism, but there is no amenorrhea, and the normal androgenic type. And sometimes these are labeled as A, B, C, D. So please remember this label. This was in the Journal of Obesity and Gynecology. This was 5 years or 6 years ago. Phenotype A is hyperandrogenism, oligomenorrhea with PCOS on ultrasound. B, hyperandrogenism and oligomenorrhea. C, hyperandrogenism, PCOS and on ultrasound. D, with oligomenorrhea, polycystic ovary on ultrasound. But mind you that phenotype B, which is the most common type, because the phenotype B, the LH is more raised than the other phenotypes, testosterone is more raised in the other, and the estrogen is the highest. So you can say the phenotype B got the highest hormone problem, high LH, high testosterone, high insulin. And sometimes we encounter non-obese PCOS, and this patient, they different also as regard hormone. And you can see that in the normal BMI PCOS, the LH is higher, and you can see also that the free androgen index is lower in the normal BMI. So we have to remember this, and you can get PCOS in normal weight girls or women. The role of thyroid is very evident, and prolactin also is very evident in PCOS. We have to remember this. And this is an important publication by Abdelazim. This was 2 years ago. They found in women with PCOS, the TSH tend to be higher and the prolactin tends to be higher as well. What is the relation? Relation is that the anti-TPO is highly relating with patient with PCOS. The higher TPO is there. And there was another publication by Romiti, so there was association between PCOS and autoimmune thyroid disease. And those very interesting meta-analysis published 4 years ago. But let me share one of our cases. We have published, this was almost 15 years ago. She was a young girl presented to us because they're suspecting Cushing, actually. She's got abdominal swelling for the last year. And she was referred to the OG1 because the CT showed large pelvic abdominal complex adnexal swelling, about 12 centimeters. And this is the CT of our patient. You can see this is the pelvis with the iliac bones. This is the sacrum. And of course, you can see a large ovarian multicystic swelling. And the weight of the patient was a little bit high. She's got the diffuse abdominal swelling on clinical exam. She's got anemia, as you can see. And this is the picture of this young girl. And of course, whenever you see this young girl, you suspect which disease. I'm hearing in the corridor that you are suspecting some endocrine problems. The cortisol was normal, so it was not Cushing, but definitely she was hypothyroid, very high TSH, very low T4. And she's got moderate pericardial effusion. And after therapy, and it took about 6 weeks to the TSH to go back to normal, and clinically there was a marked decrease in the swelling with disappearance of pericardial effusion. And look at this young girl, she looks different. And look at the CT, you can see the mass is gone. There is no adnexal mass, and the patient was saved from surgery. And this is the patient before thyroxine. This is the patient before thyroxine, and before thyroxine, after thyroxine. This is, of course, before. She is not smiling, apathetic. This is after, and now she is smiling. And most important, the CT. Before, there was a large pelvic abdominal mass, and without surgery, this adnexal multiloculated ovarian cyst is gone. And when we have reviewed the literature, they got a description of the same syndrome, the Van Wyk-Grumbach syndrome, with mega ovaries in patient with severe autoimmune hypothyroidism. Remember this syndrome. The role of prolactinemia and PCOS is very important. You can see that many of your PCOS patients get high prolactin. Why is that? Because the low dopaminergic tone associated with high prolactin will lead to increase in LH. Also, the prolactin will increase the adrenal androgen. Please remember that. And the high estrogen in patient with PCOS will lead to increased prolactin. That's why actually I'm treating many of my patients with PCOS with anti-prolactin drugs like cabergoline, despite having mildly elevated prolactin. Another important relation in endocrinology is what you call the endocrine disruptor. the famous bisphenol present in all the plastic bags and so on. And as you can see that the PCOS is more in patient consuming the endocrine disruptors. And because they actually are acting as a potent sex hormone binding, so it will increase the free androgen. Another important hormone problem is the relation with the bone. You can see that with PCOS, the PTH tends to be increased, vitamin D diminished, and calcitonin increased. This will lead to increased bone resorption and diminished bone formation. So remember the role of PCOS and the bone. Remember this graph: high PTH, high calcitonin, low vitamin D. The fifth point is the male PCOS. And this is a very interesting publication that you can get a male with PCOS phenotype. Of course, they don't have the ovaries, but they've got testes, but they got the same phenotype: high DHEAS, high AMH, high LH, high LH-FSH ratio, and high calculated free testosterone. Actually, they are insulin resistance, and they are hyperglycemic, overweight, with hyperandrogenism in the form of baldness, premature baldness at the age before 35. So remember that PCOS is not occurring only in women, but also in men. Lastly, what is our role as endocrinologists in the treatment of PCOS? Remember, the treatment of PCOS is a lifestyle modification, but also hormonal therapy is very important. For the metabolic alteration, correction of the insulin-resistant obesity and the acanthosis nigricans, metformin and GLP-1 analogs. For correction of menstrual androgenesis, metformin again, and the so-called cyclic estrogen progesterone pills, the cyclic pills. And for correction of hirsutism, you can use also the cyclic contraceptive pills, in addition to spironolactone and in addition to cyproterone. So it seems that the role of endocrinology is very important in treating PCOS. And very interesting that the metformin use will decrease the AMH. And this was a publication 5 years ago, in which by use of metformin, you can see that the AMH diminishing both in overweight and in obese patient with PCOS. So remember that metformin will lead to a diminution of AMH, and when the AMH is low, the FSH will become better. Remember that. Lastly, the use of combined cyclic oral contraceptive is very important because this will lead to diminution of LH. Secondly, the use of these pills will diminish the intra-ovarian production of androgen. Thirdly, this will increase the circulating sex hormone binding globulin, so the free androgen is less. Finally, the use of oral contraceptive pills with minimal androgenic progesterone activity will inhibit the binding of dihydrotestosterone to the androgen receptors. Lastly, but not least, even the IVF, as endocrinology, you've got a role, because you have to advise the PCOS doctor, the OBGYN, to use the lowest dose of gonadotropin. This patient, they got a low fertilization rate, higher rate of available embryos, and high rate of ovarian hyperstimulation syndrome. So we have to advise the OBGYN patient about this. At the end, dear professor, dear colleagues, ladies and gentlemen, in the last 14 minutes, I've gone through the role of hormones in PCOS. As endocrinologists, we've got a very important role on PCOS. The hormones are very important in the pathogenesis, very important in the etiology, very important in the diagnosis, and also very important role in the treatment. And allow me to thank you very much for your patience with me. And again, I'm sorry, Lily, for not being able to be physically with you. Maybe next year, inshallah. And I will be happy to answer any question or to have any comments from my dear colleagues. And thank you.